With this, I call upon Professor Gopal S. Pillai for his presentation on results of first government-supported clinical trial network run registry for diabetic retinopathy.
Thank you very much. So this is the results of the first government-supported clinical trial network registry. We formed a clinical trial network based on NBM BIRAC Government of India. So these are the 6 sites in the network, including South, West, East, and Center. And this was a sanctioned second objective of the network to form a registry. And it had about 3,699 patients of diabetic retinopathy in the registry over 2 years. So there were a lot of quality checks that we had mentioned because there were 700 data variables for each patient in the registry, each of those 3,699. So there was a lot of quality checks, and these were the number of audits conducted by central agencies as well as the lead site. And objectives of this particular study is to look at descriptive statistics on diabetic retinopathy presentation among these patients. Are there any geographic variations in the presentation from different regions of India? What are the factors affecting visual acuity? And what are the results in the management of diabetic retinopathy from this large database? These are cases across all geographic regions. And as you see, this is a tertiary care center data. So proliferative diabetic retinopathy significantly was high. And you could see here that in non-proliferative diabetic retinopathy, moderate in PDR was higher. And in proliferative diabetic retinopathy, lasered PDR, vitreous hemorrhage and tractional retinal detachment were there. Now, across age groups, when you looked at it, West had a lot of older patients, and women significantly were higher in the South zone. You could see that when you looked at the comorbidities, these are the smoking and the alcohol, you could see that East had the highest amount of smoking, and South had the highest amount of drinking in the diabetic retinopathy patients. These are the comorbidities. I just want to take a minute to say that central zone was represented by Chitrakoot, which is a rather rural zone. And you can see that the hypertension, coronary artery disease, CKD, dyslipidemia are all so much less in the central zone as compared to here. You can just see this dyslipidemia, 47% versus 1% in the rural zone. So distribution of diabetic retinopathy into, we had the logmar scale, and you could see that in the West, they had the higher visual acuity presenting, and in the East, the visual acuities on presentation was lowest. Obviously, non-proliferative diabetic retinopathy had better visual acuity than proliferative diabetic retinopathy. And now coming on to the factors which influence vision, the patients were grouped into best corrected visual acuities, more than 0.5, which is less than 6 by 18, or more than 1 logmar, which is more than 6 by 60. And we looked at all these factors, and logistic regression analysis was performed. Because of the high numbers, age, BMI, diabetes duration, coronary artery disease, dyslipidemia, hemoglobin levels, cholesterol levels, and urea levels were significantly associated with worse visual acuities than 6 by 18. These were predictors. But then we had, in the eye, obviously, proliferative diabetic retinopathy, vitreous hemorrhage, and tractional retinal detachment were having a poorer visual acuity. So we did a logistic regression to find out which among these are more appropriate. And so we adjusted odds ratio was done. And then a p-value was again calculated. And then we found out that BMI, diabetes duration, hemoglobin, and urea are the 4 factors which can actually predict visual acuity less than 6 by 18. Similarly, even though all these factors, including age, BMI, diabetes, coronary artery disease, dyslipidemia, all had significance, but logistic regression showed that diabetes duration was the only factor which had predicted visual acuity worse than 6 by 60, apart from diabetic retinopathy grades, vitreous hemorrhage, and tractional retinal detachment. Now let us look at the treatment results of diabetic retinopathy here. Vitreous surgery had the highest change in visual acuity, followed by intravitreal injection and laser. The other medications include the posterior subtenon injection and the NSAIDs and the antioxidants, etc., which did not have any statistical difference. Now coming on to the change in logmar with the treatment, is that the different injections and the vitreous surgery which showed the maximum logmar improvement, and laser had in fact a little less visual acuity. These were the types of intravitreal injections and change in BCVA. So to conclude, in 3,699 patients across India, presentation of DR to tertiary specialists is very late. many patients of PDR by the time, about 50%. There's a gross regional variations across zones in terms of gender, age, mode of presentation, visual acuity, etc. BMI, duration of diabetes, hemoglobin, urea. These are the 4 factors which predict vision below 6/18. And duration of diabetes is the only factor which predicts visual acuity below 60, other than the ocular factors including PDR, vitreous hemorrhage, and TRD. Treatment with surgery, laser, and injection provides visual improvement in the real world scenario also. Thank you very much.
It has been a very extensive study which you have done. What was the time period?
This started in 2019, but the registry started in 2020 mid, and it went on to 2023 early. So it's 2 years.
So you had camps there?
No, they were all tertiary care, hospital-based data. It is a clinical trial network across the hospitals. MOUs were signed. There were similar harmonization of the standard operating procedures, ethics committee harmonizations. A lot of these things were done.
I think it's a very good study.
Thank you.